All right, good afternoon, everyone. Welcome to our last Zaremski lecture of the semester. And we want, first of all, to thank Miles and Elena Zaremski for their generosity in supporting this lecture series, and we wouldn't be able to have these without them. I will be posting the CLE code in the chat later in the program, and I will also announce it. And if you are online, please put any questions you have in the Q&A. We do have somebody monitoring the Q&A. Don't put it in the chat, just in the Q&A. So we are delighted to have with us today Professor Jessica Mantel from the University of Houston Law Center. She is the co-director of the Health Law and Policy Institute down in Houston, and she also has had several previous government positions in Washington, D.C. She worked as a senior attorney in the Office of the General Counsel for the Department of Health and Human Services, focusing on Medicare matters. Before that, she was a health policy analyst in the Government Accountability Office, evaluating Medicare payment issues. And Professor Mantel also practiced in the private sector. She was an associate in the healthcare department of the prestigious Boston firm Ropes and Gray. Professor Mantel began her legal career as a judicial clerk for the Honorable Karen Nelson Moore of the U.S. Court of Appeals for the Sixth Circuit right here in Cleveland. Professor Mantel is widely published, including in Health Matrix, yay, and in the Case Western Reserve University Law Review. And she publishes about a large number of key healthcare challenges. Her talk today is entitled Coordination, Not Competition, Achieving Value-Based Care Through Shared Governance. And I will turn it over to you, Professor Mantel.
Well, thank you, Case Western, for inviting me to speak today as part of the Zaremski Law and Medicine Forum. I know this forum has hosted many distinguished speakers over the years, so I'm really honored to be giving today's talk. So the U.S. healthcare system stands today at a critical juncture. There's widespread recognition that we must move from volume-based to value-based care delivery models. And many contend that the way we should achieve this is by shifting from fee-for-service to alternative payment models that link providers' payments to the quality and efficiency of care that they deliver. But a couple of years ago, I was at a conference of health law professors where some of my colleagues asserted that alternative payment models have been a failed experiment. And this is really contrary to the conventional wisdom among payers and policymakers. So the conventional wisdom asserts that if we just keep experimenting with different payment models, we will eventually figure out what works best, and ultimately we can then successfully transform the healthcare delivery system. So where do I stand on this debate? Well, I think it's premature to give up alternative payment models. But my colleagues are right in the sense that alternative payment models have generated mixed and largely disappointing results. Payers, for example, report that just too few healthcare providers have fundamentally changed how they care for patients. And as a result, we've seen uneven outcomes when it comes to improvements in the quality of patient care and reductions in healthcare spending. So if we keep doing what we've been doing, I think my colleagues are right in that we will continue to see disappointing results. So in my talk today, I will argue that transforming the healthcare delivery system requires more than simply changing how we are going about paying healthcare providers. It also requires that we fundamentally rethink how we regulate in the healthcare finance space. So my talk today will unfold in three parts. First, I'll explain why fee-for-service payment models are problematic and explore how value-based delivery models linked with alternative payment approaches can, at least in theory, create a more efficient and equitable healthcare system. Second, I'll examine our current legal regime for healthcare finance, which envisions transforming the healthcare system through market forces. And I'll explain why this market-driven approach actually creates obstacles to value-based care and fails to address other barriers to healthcare transformation. And then finally, I'll outline a new governance approach that I call value-based governance. Value-based governance emphasizes the public and private sectors working together to move the healthcare system to value-based care. And I'll explain why a more collaborative process, so one where all stakeholders are actively participating in policy development and implementation. I'll explain why I think this may be a more effective approach than our current regulatory approach. So let me start with some background on how insurers and government healthcare programs traditionally pay for healthcare. And many of you are probably familiar with this, but you're a varied audience, and I just want to make sure that we're all on the same page. So traditionally, we pay providers on the basis of fee-for-service. And under fee-for-service, providers receive a separate payment for each service rendered. So a separate fee for each patient visit or diagnostic test or medical procedure. And this creates perverse incentives that contribute to systematic inefficiencies across our healthcare system. So first, fee-for-service rewards volume over value. It encourages providers to perform more services regardless of their benefit. So if a provider is on the fence as to whether they should order another diagnostic test or perform a surgical procedure, fee-for-service nudges them to err on the side of ordering that test or performing that procedure. And that's because providing that additional service generates an additional fee-for-service payment for the provider. Second, because fee-for-service pays higher rates for more complex patient care, it skews the healthcare delivery system toward expensive, specialized care over primary care. Third, fee-for-service penalizes providers who reduce costs through prevention or better care management, or who mitigate the non-clinical conditions that adversely impact health, like food insecurity and poor housing issues. And that's because healthier patients need less care, and under fee-for-service, less care for patients means less revenue for the healthcare provider. Fourth, because fee-for-service pays providers the same fee regardless of how good a job they're doing, it fails to hold providers accountable for the quality of care that they provide or for a patient's health outcomes. So in other words, fee-for-service doesn't create incentives for providers to improve the quality of care that they give patients. And finally, fee-for-service promotes care silos. When providers receive a separate payment for each thing that they do, it encourages providers to focus on their individual services rather than stepping back and taking a coordinated, holistic approach to patient care. And these incentives have resulted in our having a healthcare system that is largely organized around the detection and acute treatment of disease. And this is at the expense of primary care, preventive care, and care coordination. Now, these problems with fee-for-service are widely recognized, and many therefore called that for us fundamentally transforming how we care for patients. Specifically, there's a desire to move the healthcare system to what we call value-based care. And as this term suggests, value-based care is focused on maximizing the value of the care provided to patients rather than the volume or intensity of care. So value-based care's key features include a focus on primary care, prevention, and evidence-based treatment protocols. It emphasizes comprehensive care management that addresses both the medical and the non-medical needs of patients, so the so-called social determinants of health. And relatedly, value-based care emphasizes enhanced care coordination across providers, such as greater integration of primary care with behavioral health care and social services. So nudging the healthcare system to value-based care requires changing how we pay providers. So it involves replacing fee-for-service with payment approaches that are built around financial incentives that reward providers who successfully implement value-based care models. And I'm going to use the term alternative payment models, or APMs, to describe these alternatives to traditional fee-for-service. Now, some alternative payment models simply layer these financial incentives on top of fee-for-service. For example, some APMs continue to pay providers a fee for each service they provide, but also pay bonuses or higher reimbursement rates to providers who do well on selected quality and efficiency metrics or performance metrics. And then conversely, a provider who does poorly on these patient outcome metrics or has low efficiency scores may be penalized with, let's say, lower reimbursement rates or other financial penalties. But other APMs will do things like pay providers a fixed monthly payment to support their care management and coordination of patient care. And then more advanced APMs shift financial risk to providers through things like capitation or other population-based payments. And what these APMs all have in common, though, is that they're designed to give healthcare providers financial incentives to find innovative ways to improve the quality of patient care while reducing healthcare spending. So the trillion-dollar question is whether these APMs are in fact working. And the answer so far is, well, there have been some success stories. So there's been some providers that have seen improvement in patient care and in lowering costs. I think it's fair to say that overall, people have been disappointed with the results of APMs. So that leads to another question, which is, why isn't all this working? So let me turn now to why I think APMs are having limited success. And my explanation starts with a discussion of our current regulatory approach to healthcare finance. So you often hear that the healthcare sector is one of, if not the most regulated industry in the United States. And this generally is true. But when it comes to alternative payment models, payers have a lot of autonomy in how they design and implement their APMs. So in the world of healthcare finance, we generally regulate healthcare payers in their individual capacity. And what I mean by this is that our regulatory focus is directed at payers' discrete, one-on-one interactions with consumers and with providers. So that means the goal of our current regulatory approach is to facilitate these marketplace interactions and ensure that those interactions are fair as between the two parties. So first, we have laws whose aim is to support a robust health insurance market by generating confidence in private insurers. For example, we have strict financial standards that are designed to prevent insurer insolvency. And we have contract law that ensures that payers deliver on promised benefits. Second, our current regulatory framework targets market failures like information asymmetries. So we have requirements that make sure payers, for example, clearly disclose their insurance policies, terms, and conditions. And then third, we have laws that focus on fairness concerns and remedying in power imbalances between payers and either patients or providers. For example, the patient rights movement that followed the emergence of managed care in the 1990s led to laws like coverage mandates and provider network adequacy requirements. We have other laws that protect providers through mechanisms like prompt payment requirements. But when it comes to regulating insurers as value-based purchasers, payers have a lot of autonomy. So we take a very hands-off regulatory approach with respect to how payers design and implement their alternative payment models. And as a result, payment policy in the United States largely is based on the cumulative impact of millions of decentralized decisions made by independent private payers and public payers like Medicare and Medicaid. So in other words, our current regulatory approach promotes this bottom-up approach to healthcare finance. And this reflects this belief in the power of market competition and innovation. So it reflects this idea that when it comes to healthcare payment policy, the marketplace will eventually figure out what works well and what doesn't. And that this market competition among payers will then eventually lead to a better healthcare system that provides higher quality care and more efficient care. But when we look at the empirical research on APMs, it suggests that this market-driven approach is not working out as well as we hoped it would. And the research in this area highlights several themes, and I'll touch on all of the themes, but I want to focus on the first theme, and that's the problem of misaligned payment approaches. So individual providers have contracts with multiple payers, and I'm talking now about both public payers like Medicare and Medicaid, as well as private commercial plans. And so this means that an individual provider must simultaneously manage different financial incentives and disparate payment rules and performance metrics. And when providers have to operate under all these different rules and financial incentives, it creates administrative complexity for providers that drains resources from patient care. It results in diluted financial incentives, and it sends providers conflicting signals about what they should prioritize for improving their patient care practices. So imagine the administrative burdens you would face as a provider when you simultaneously must juggle multiple payer contracts. For example, you may be managing hundreds of different performance metrics, which is going to increase your data management burdens. You also have to understand and manage lots of different rules for things like how a payer is going to attribute patients to different providers, or payers' rules for qualifying as an accountable care organization or a patient-centered medical home. And for some providers, understanding and managing all this creates a lot of confusion, and managing it is just simply beyond their capacity. And that's especially likely to be the case for small or under-resourced providers. And then for some providers, the higher administrative costs associated with managing all these different payment rules can weaken the business case for investing in practice transformation and shifting to value-based care. And relatedly, some providers report that this administrative complexity does not leave them with sufficient time to just figure out the best strategies for improving the quality and efficiency of patient care. Variation across APMs can also dilute the financial incentives under any individual payment model. So a single payer's APM typically will cover just a small percentage of a provider's patient panel. And this means that financial rewards under a payer's APM may be too small to justify the provider making the effort to transform their practices. For example, take the case of a payer giving a primary care provider a monthly payment for care management activities. Now, providers will typically implement practice changes across all their patients. So a provider who invests in those care management activities is going to change their practices for all of their high-risk patients. But if they receive that monthly care management fee for, let's say, only 15% of their patients, that likely will be insufficient to support their investment in care management activities across their entire patient panel. In addition, when a provider is operating under multiple APMs, they may face conflicting financial incentives. For example, typically a provider has a mix of fee-for-service arrangements and risk-based contracts. And as I mentioned a few moments ago, fee-for-service is about rewarding high-volume or high-intensity care. In contrast, value-based care and alternative payment models emphasize lowering costs and spending more time with individual patients to better understand their needs, and providing care management and care coordination. But this means that a provider who transforms their practice in ways that will allow them to be successful under alternative payment models may then lose money under their fee-for-service contracts. And some providers refer to this as a two-canoe problem. They say it's like having one foot in two canoes that are moving in opposite directions. Relatedly, when a provider has juggled different payment models, they receive mixed signals from payers as to where they should target their practice transformation efforts. So payers, through their performance metrics, their operational requirements, and their financial incentives, they highlight the dimensions of care delivery that they are going to reward. But payers often reward different things, especially given differences in the patient populations they insure. So Medicare is going to emphasize things like care coordination, given that elderly patients often have multiple chronic conditions, while payers covering younger, healthier populations may emphasize improvements in maternal care. And many providers report that this complicates their efforts to devise a meaningful response to the wide range of incentives they face. So there was one physician practice manager that said, this is like having 50 people shouting their priorities at you at the same time. So this misalignment across payment models has unfortunately deterred some providers from participating in APMs or fully investing in more advanced value-based care delivery models. And overcoming these challenges requires greater alignment across payment approaches. So we need payers to coordinate with one another, but that is just not the way a competitive marketplace typically works. Now, the research reveals other barriers to value-based care, which I will just, in the interest of time, touch on very briefly. So another theme we see is that practice transformation is hard. Shifting to value-based care requires significant investment in things like upgrading electronic health records, hiring new staff like care coordinators and case managers, and developing new care processes. And many providers lack the expertise and resources to do these things on their own, so they need help from payers. So they need payers to provide technical assistance on how providers can transform their patient care practices, or providers need payers to subsidize their upfront investment in value-based care. But free rider concerns can deter payers from providing this help. So if a provider's care transformation is financed by, let's say, payer A, the changes the provider makes will also benefit payer B's patients. So this means there's really not any competitive benefit to payer A in helping the provider adopt value-based care practices. And that creates this classic free rider problem that has led to too few payers helping providers make the transition to value-based care. Another barrier to value-based care is our healthcare system's underdeveloped data sharing infrastructure. Data sharing is just key to operationalizing many of the components of value-based care. For example, primary care providers say that it's very helpful to them when they receive real-time alerts that one of their patients has been discharged from the emergency department or from the inpatient setting. But currently there are significant gaps in our health data sharing infrastructure, so very few primary care practices receive these real-time alerts. And these gaps in data sharing functionality make it more difficult for providers to successfully implement certain aspects of value-based care. And finally, value-based care depends on having a healthcare workforce that has a sufficient number of primary care providers and behavioral health specialists and individuals with skills in care coordination and case management. But we have shortages in all these areas. And providers report that these workforce challenges pose a barrier to their successfully transitioning to value-based care. Now, I want to emphasize that a common theme here is that lowering these barriers to value-based care cannot be solved by individual actors or by the marketplace. Rather, it requires that key stakeholders work together to address these challenges. So if we continue to rely on market competition, so if we continue to take this bottom-up approach to payment policy, these problems I've identified will persist, and we'll continue to see limited progress in moving the healthcare system to value-based care. Now, one might think this means that we should replace our bottom-up, market-driven approach with a top-down regulatory approach. So one where the public sector takes the lead in addressing these challenges through things like command and control regulation. For example, we could address the payment misalignment problem through regulations that force payers to take a more uniform, coordinated approach in how they design and implement their alternative payment models. But broadly speaking, there's growing recognition that a top-down governance approach is ill-suited to address many of the challenges we face in modern society. In today's knowledge society, government agencies do not have a monopoly on relevant expertise or information. Rather, often that necessary knowledge and resources is spread across society, including across the private sector. In addition, in our modern world, the pace of change is accelerating, but a traditional governance approach that relies on command and control regulations lacks flexibility. It's very hard to quickly adapt policies that have been adopted through notice and comment rulemaking. Our traditional top-down regulatory approach also lacks feedback loops between government agencies and key stakeholders, and this makes it more difficult to identify and address emerging problems or opportunities for improvement. Finally, in our increasingly complex interconnected world, problems often span multiple domains and require a range of integrated solutions. But government agencies often operate in their own silos and do not coordinate with one another or with private actors who are also vested in solving these problems. And so, growing recognition of the limitations of both a bottom-up market-driven approach, but also that top-down approach, has led to interest in what I'm going to call more horizontal approaches to governance. And these are sometimes called shared governance, collaborative governance, or public-private partnerships. So collaborative governance envisions shared responsibility between public and private actors for solving societal problems. So all stakeholders are involved in the policymaking process, from identifying policy priorities to developing and implementing policy solutions and evaluating policies for their effectiveness. And importantly, these new governance approaches embrace the broader conceptualization of law. So one that moves beyond traditional command and control regulation and incorporates so-called soft law approaches that rely on more cooperative policy instruments. So instead of relying just on legally binding rules issued unilaterally by a government agency, coordination might be achieved through voluntary standards or guidelines, or by relying on economic incentives that nudge actors toward desired conduct. Now, these new governance approaches don't completely abandon legally binding rules or so-called hard law. They often do, though, rely on just this mix of soft law and hard law approaches. But even relying on that traditional command and control regulations, these regulations will emerge through a more collaborative process like negotiated rulemaking. So there's a consensus-based approach to developing policies where a government agency will convene the relevant stakeholders and facilitate their negotiating the regulations. So bringing this to the world of value-based care, there seems to be an emerging trend of some states adopting collaborative governance approaches to address the barriers to value-based care that I talked about earlier in my presentation. Similarly, CMS's Medicare and Medicaid payment demonstrations are adopting a more collaborative governance approach in an effort to align payment policies across Medicare, Medicaid, and private plans. And I call this value-based governance. So the question is whether this new approach to governance could be more effective than our current regulatory approach when it comes to helping our healthcare system transition to value-based care. And I want to present some arguments for why I think the answer to this question might be yes. So value-based governance brings together the relevant stakeholders, government agencies, payers, providers, patient representatives, and other groups. And in doing so, it allows stakeholders to pool their ideas, their resources, and their competencies. Now, under value-based governance, then, stakeholders will jointly identify the relevant policy goals and priorities, and then together develop and implement policy solutions to address the barriers to value-based care. This creates opportunities to leverage their collective expertise and resources, including that of private actors. For example, payers and provider organizations, along with universities, can contribute their respective expertise and resources to jointly develop programs that provide technical and financial assistance to providers that are struggling with the transition to value-based care. Importantly, when the policymaking process incorporates multiple perspectives, this often results in better policy solutions, as well as broader support for those solutions. For example, payers may be willing to, or more willing to, align their APMs when they have a seat at the policymaking table and have some ownership of the policies that are negotiated through a shared governance process. Flexibility and experimentation are additional key features of value-based governance, as is continuous learning through more open lines of communication that allow for data collection and stakeholder feedback on what's working, what's not working. So moving the healthcare system to value-based care is a complex, monumental challenge. And to be honest, we don't really know the specific policies that will be most effective in overcoming these barriers. So it would be premature and maybe even irresponsible to start imposing rigid, legally binding rules from above. So instead, it might be better to experiment first with these soft law approaches, such as voluntary rules that foster greater alignment across payers and their APMs. And then the governance process employs these soft law approaches. It's easier to then modify these policies in response to stakeholder feedback. For example, among states that have employed value-based governance to address data sharing challenges, some states initially tried one approach, only then to realize they have to modify their approach based on feedback they got from providers flagging various problems. Value-based governance also emphasizes integration across policy domains. So moving the healthcare system to value-based care is a multifaceted challenge that is going to require a range of coordinated policy interventions. And by bringing together multiple government agencies as well as private actors, value-based governance can support developing coordinated policies that together are designed to achieve a common goal. For example, the state of Rhode Island has sought to strengthen its primary care system and promote patient-centered medical homes. To achieve these goals, Rhode Island has taken a multi-pronged approach. So they adopted a core set of primary care performance metrics that all payers must use. They've developed a uniform multi-payer payment model for primary care practices seeking to qualify as patient-centered medical homes. Stakeholders have also developed technical assistance programs to help primary care providers qualify as patient-centered medical homes. They've invested in health information technology that supports primary care practices, and they've expanded a loan forgiveness program for their primary care providers. And so value-based care, by bringing together all stakeholders, supports developing these kind of integrated approaches that together are designed to achieve a single policy goal. As for the government's role in value-based care, rather than sitting at the the top of the governance hierarchy as they do under sort of traditional top-down governance models. With value-based care, the government acts as a convener. So they bring everyone to the table and then facilitate a more collaborative policymaking process. And the government also helps coordinate activities across the public and private sector to ensure that the policymaking process respects public values like health equity. So as I mentioned, this shift to value-based governance is happening in a handful of states. We also see value-based governance happening in CMS payment demonstrations. So there's a need to start studying these value-based governance models. We need to evaluate whether the potential benefits that I've just identified are actually playing out in practice. In addition, because value-based governance approaches vary significantly across states, we need to evaluate whether certain approaches work better than others. For example, some states are relying primarily on soft law approaches, where other states are combining soft law and hard law. So what are the benefits or limitations of a soft law approach versus a more hybrid approach? It's also important to ensure that value-based governance is an inclusive process and is not co-opted by powerful interests that is a dominant payer. So we need to examine value-based governance processes to see whether there are safeguards that can be put in place that will promote a more inclusive process. And then value-based governance also raises a lot of federalism issues. This may be an area of policymaking that's ripe for a more cooperative federalism model where CMS proactively encourages or supports states implementing value-based governance. It also may be important for CMS to be at the table and participate in each state's value-based governance process, given the size of the Medicare program and its impact on the healthcare system. At the same time, we need to recognize that if Medicare were to abide by 50 different states' value-based care policies, this could result in a lack of uniformity in Medicare payment, and that also brings its own set of concerns. So I think there's a lot of questions around what CMS's role should look like when it comes to value-based governance. And finally, we need to look at whether existing laws, like our antitrust laws and our ERISA preemption rules, we need to look at whether these rules could frustrate state efforts to address the barriers to value-based care through value-based governance. So that concludes my presentation. And at this time, I welcome your comments and questions.
Thanks so much, Professor Mantel. That was terrific. I am going to take the moderator's privilege and ask the first question, which is, I wonder if you could speak a little bit more about the issue of federal involvement versus state involvement. I just read they've today apparently fired 10,000 HHS workers. So if we leave a lot of this to the federal government, is that realistic in this climate? I don't know how they could handle new tasks. And then the ERISA problem is very problematic for the states because any regulation of insurance on the part of the states is not going to reach self-insured plans. And so I'm wondering if you could address those two challenges in a little bit more detail.
Sure. Great challenges. I hope to study them more closely in the future to give you a better answer to your question. But I think that when it comes to trying to lower these barriers to value-based care, there is this question of, do we want to do this at the federal level or do we want to do this at the state level? And obviously, there's some challenges happening right now at the federal level. But even if we went back or maybe forward in time and we had a more robust federal government in form of HHS, I still think there's a lot of value in having these policies we try at the state level. I mean, healthcare in many ways is local. States do differ in terms of the challenges they face. And I don't think it's been one size fits all when it comes to the policy solutions. And I think this is an area of ripe for a little labs of democracy idea where we really do want to experiment in different ways to see what might work and what might not work. And so having states experiment would be of value. So I do think a lot of the drive for value-based governance should be happening at the state level. But then that raises the question, like, well, what does it look like for CMS's involvement, right? Because Medicare is huge. And there are cases of states doing some things and Medicare not sitting at the table and not participating in the policies being developed. And when that happens, you then have still this fragmentation in so what's happening on the payer side of the equation. So maybe you have a lot of the payers in the state agreeing to do something, but if Medicare is still doing something differently, all those problems I talked about with the misaligned payment policies is still happening. So I guess what I envision, and I have to think a lot more about this, is that maybe CMS will do something similar to what it's done with the Medicaid expansion, where it says, here's 5 approaches that we would be willing to participate in states. You have flexibility within these, 4 or 5 different approaches. And so it does put some limits on what states can do, but it also brings CMS to the table in the states, as long as they're agreeing to one of these frameworks that CMS says it's okay with. And then it means instead of there being 50 different versions that Medicare has to follow, if they're participating, maybe there's just 4 or 5 different approaches that Medicare will take when it comes to like payment alignment. So that's kind of some early thoughts I have about your first question. And then the second question, dealing with ERISA preemption, is that a lot of what's happening at the state level is starting off as voluntary, but so we have whoever wants to participate, these payers coming to the table along with other stakeholders to talk about these problems, but often missing from the table are self-insured employers. And I think even if you moved from, and often we go from voluntary and we'll start having more mandatory rules that would ensure payment alignment, but again, those self-insured employers don't have to conform. And so you end up with, again, sort of this fragmented payer market where maybe a lot of payers are going along with whatever the rules are that the states develop to align the payment approaches, but then self-insurers are over here and they're doing their own thing. And again, it creates that problem for the provider who has now multiple approaches that they're still simultaneously juggling. So I think this ERISA preemption is this big problem. And my hope is that, and people have known this for a long time, my hope is that Congress will change the laws, right, and kind of take away ERISA preemption in this space so that the employers have to sit at the table and have to go along with whatever policies are developed.
Or maybe there'll just be an executive order that will solve everything.
Yes.
Okay, Lucas, do you have, I thought I saw a Q&A online. Would you like to present it?
So there's a question from the Zoom audience that asks, are you familiar with the Pathways Community Hub model of care coordination? It's a care model that ties payment to successful outcomes, and it's aimed at many of the same objectives you are looking for.
So I know a little bit about the hub model, and I'm not an expert on that. I would kind of point everyone to my colleagues at Seton Hall that are doing a lot of work on this. But you're right, my understanding is it's a way of supporting providers, particularly the smaller providers who are struggling to make that transition to value-based care. And so I see it as a potential solution to that part of the problem that I talked about. And I think it's a model that could be followed in other states where what I would envision happening is they all come and sit at the table and we're talking about this problem of providers needing support in transitioning to value-based care. And maybe some states will say, there's this Pathways Community Hub model that is helping hub model, right? But it's a model that I think, this way I understand it, needs. I don't think it's great that some communities have been able to create it, but I think it needs kind of collective support and collective investment by all the stakeholders to help get it off the ground in some places.
Any questions in here? Lucas, was there another question? I think I saw there was.
Yeah, there's a second question from Zoom that asks, given the wealth of information on behavior needed for better health, for example, smoking causes numerous health issues, where does individual responsibility fit in?
That's a great question. And I kind of omit, because of time, I omitted this from my talk, but when I think about what value-based governance might look like, I think there's room for this particular issue that you're talking about, and I'm going to kind of label this population health challenges. So when we look at what some states are doing with their value-based governance models, they're addressing those issues I talked about, like payment misalignment and workforce challenges and data sharing. But another thing that they often are doing is population health initiatives. So for example, you might have a state that says, we really want to focus on maternal health. Right? We think the complications that we're seeing related to premature births or something is too high. And there might be different things they do to address that in the realms that I talked about, but I could also see them bringing in some policies at the population health level. And so it's part of, it fits in with what I talked about towards the end of wanting these integrated policies, all like working together to achieve whatever policy priorities or goals have been agreed upon. And I see kind of population health initiatives as part of that integrated policy approach.
So, since the evidence shows that so far value-based payment approaches are not effective, people might argue, well, then they should be abandoned. They're too complicated. They create a lot of headaches for providers. They don't work. So what would be your argument that we should persist in pursuing them?
So, I mean, I think this, to say, it's not, I don't want to say that they're not working. I think they're just not working as well as people hoped, right? I mean, there's some evidence, the evidence is mixed, right? There are some success stories. I think it's like two responses. First is, well, if we don't do these alternative payment models, then what are we doing? And I think the default is fee for service. And well, that wasn't working so well either. So I don't think that's the answer. And I think, though, kind of my second part of that is, well, before we abandon alternative payment models, value-based care, we have to look at, well, why are they not working? And can we do something about that? And when I look at the literature that evaluates different alternative payment models, you just see these themes over and over again. You see providers talking about, like, it's really hard, I'm juggling like so many different payment models. Or you see them saying, I want to do care coordination, but I can't find people that are skilled in care coordination. There's not enough of them out there. Or I can't get the data that I need to really effectively implement this. So those are problems that we might be able to do something about. So I guess my response is, like, before we give up on alternative payment models, we should think about whether we can address the problems that are leading to these disappointing results. Especially given that I think the default of fee for service is also problematic.
Okay, just before I forget, the CLE code is 579496. 579496. And have you put that in the chat?
I have.
Okay, it's also in the chat, so you should have it. Any further questions online?
One more from Zoom asks, does expanding coverage for long-term care, which currently isn't covered, like with assisted living facilities, fit into this at all? to address needs of the expanding senior population?
So I'll be honest, I've not thought about that. I tend to think of long-term care as kind of another problem that I've not really heard people link long-term care to value-based care. But that being said, I could imagine that when you bring stakeholders to the table, that someone says, hey, if we want to improve care for particularly an elderly population, a lot of who need long-term care. Well, we got all these problems with long-term care that need to be fixed. So we need to, when we're thinking through this integrated policy approach where we're going to have multiple policies working together, maybe some of those policies would address the long-term care issues.
Any other questions in the room? Okay, well, I think we need to end so people can get to their 1 o'clock classes. Thank you so much. That was really illuminating and fascinating. And thank you to everyone who is attending.